Hi, everybody. My name is Rachel. I think I've spoken with many of you on the phone, getting set up for this seminar. Thank you so much for joining us today. If you cannot hear me, feel free to type something in the Q&A box. We'll try to sit closer to the screen, but we're just glad you're here with us tonight. My name, like I said, is Rachel. I'm one of the patient educators here on the local Hampton Roads team with Boston Scientific. We are honored to do this tonight with Orthopedic and Spine Center. Dr. Jenny Andrus is going to be speaking tonight. We also, after Dr. Andrus speaks, are going to have a patient ambassador speak, and then we'll also have some time for question and answer. So it'll be about maybe 45 minutes. Do have a couple housekeeping things to go over before we get started. Just so everybody knows, you can see my screen and you'll be able to hear us and Dr. Andrus when she speaks, but no one can see or hear any of the patients on the line. That's to protect your privacy, so just know no one can see or hear you. Everything's disabled. You can also use the Q&A box to ask questions. You'll see it pictured on the screen, what it looks like to click. Again, those questions will not be seen, so privacy is protected there as well. If you have a question that you do not want to ask live or have us address live, feel free to email or call me. My number's on all the invitations, the emails, feel free to do that and we'll be following up with you that way. We'll also be recording the seminar and sending out a link where you can watch it, share it with friends. That will be coming out in an email in a few days. Like we said, Miss Sandy, she's our patient ambassador. She is a volunteer patient, probably has a similar pain story or chronic pain story as some of you tonight. So you'll be able to hear how she has treated her pain and really gotten her life back. And again, she is a volunteer. She's just here to share her time. I think that is all of our housekeeping. I'm going to pass it over to Dr. Andrus. She's going to share and speak with you tonight. She is an interventional pain management specialist here at Orthopedic and Spine Center. Thank you, Dr. Andrus.
All right, good evening. This is so weird. As much Zoom as we've been doing with COVID, I'm still not totally with it. I'd rather see you guys. But anyway, I am an interventional pain management physician here at Orthopedic and Spine Center. I do a lot of spinal cord stimulation, so that's going to be the bulk of our talk today, but there's a couple other things that we're going to hit on as well. All right, so let's just kind of skip over this because this isn't that important. All right, so when we're talking about pain, we really want to break it down into two basic things initially, okay? The first thing is whether it's mechanical or nerve related or some combination thereof, right? So mechanical pain is like a rotator cuff tear. Okay, so there's something wrong with the rotator cuff. It hurts when you move it. That kind of pain is not the type of pain that we're going to be treating with something like a spinal cord stimulator. Nerve pain is different. Nerve pain can be from a damaged nerve, an irritated nerve, a compressed nerve. It can be from a nerve that was compressed, was damaged, but didn't completely heal when it was fixed or when that compression was taken off of it. And the symptoms of it are a bit different. So people will say, you know, I'm crazy. You're going to think I'm crazy, doc, but let me tell you, my feet feel like they're cold, but my wife touches them and they're warm. That's totally a normal sensation with nerve pain. Pins and needles, people will say it feels like ants are crawling on my skin, or I don't have to do anything, and all of a sudden I'll just get this shooting pain that'll go and it'll come, and I don't have to do anything to provoke it, or sometimes I can't do anything that makes it go away. All of that is very common and normal for nerve pain. Now, most of what I treat is spine pain, and spine pain, most experts believe, is in chronic conditions likely a combination of the mechanical and the nerve pain. So we may use different types of treatments to trying to get at two different issues. Now, 90+% of Americans have back pain at some point in the year. Okay, so just having pain is not really the biggest issue. Not being able to do what you want to do is the biggest issue. Okay, can you go to work? Can you do the recreational things that you like to do? Can you garden? Can you hang out with your grandkids, ride a bicycle? That's the stuff that matters in the long run. So we're going to talk about this a little bit more when we talk about expectations with some of these pain treatments, but I am less interested in a reduction in pain compared to how interested I am in improvement in function. So let me explain that, because it sounds like I'm a pain doctor and I don't care about pain. But when your pain is really this big and it's all you can see is pain, 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 it's like 10 out of 10. It's the worst pain. And I do some treatment to you and I make it this. Okay, so now you say, okay, it was 10 out of 10, now it's 5 out of 10. I'm so happy. Some period of time, that 5 is going to become the new 10. So we don't want to chase a pain-free. A lot of you probably had this experience where something's really killing you, like you've tweaked your shoulder, it's so bad, so bad. And you feel a little bit of backache, but man, this shoulder's killing you. Shoulder gets better, and all of a sudden you're really paying attention to that back, and that back's really hurting. So your brain is thinking about the predominant sensation in those situations. I can't chase a pain-free for a lot of my patients. And I wish I could. And if I could make people pain-free, you'd never be able to get an appointment with me. But I want people to be pain-free. But that's not a reality now, currently, for most chronic pain patients. So what we're really looking for is a significant reduction in pain, but more importantly, an improvement in function. So I've been at OSC about 12 years now. And my patients that have been coming to see me for years and years and years that have a stimulator, they're not telling me they're happy because their pain was an 8 and now it's a 4. They're telling me they're happy because their life went on and they continued to work, or they continued to garden, and they continued to exercise, and they could walk through the grocery store without having to stop, the things that are really important in life. Now, there are a lot of steps that we're going to take before we're going to get to something like an implant, or even necessarily until we get to something like an intervention like radiofrequency ablation or an epidural. Right? So first things first, we're going to try some of the simple medications, but a lot of folks have a lot of issues where they can't take a lot of those medicines. Okay, so for instance, the NSAIDs, I have a love-hate relationship with them. They do a great job for a lot of people with their pain, particularly arthritis pain, but they come with issues with the GI tract and kidneys and increased risk of heart attack and stroke. And so for a lot of my patients, they're just not appropriate. Physical therapy is going to be a mainstay. And a lot of times patients will say to me, why should I even do physical therapy? Physical therapy is going to do nothing for my spinal stenosis. You are right. It is not going to fix the fact that you have spinal stenosis. It's not going to fix the fact that the spinal canal is too narrow. Okay. That being said, you have a lot of secondary pains that come from the original thing. And I'm specifically talking about spine pain, but there's a lot of secondary pains that come from that: ligamentous, tendinous, muscular, soft tissue type pain. And for many patients, those secondary pains are actually as bad or worse as the root cause, the spine pain from the stenosis. So the physical therapy addresses all of those things. It also improves mobility and makes the outcome of all of our interventions better. So don't underestimate the power of that. And when we want you to go back to it, it oftentimes has less to do with pain relief and more about getting you stronger. TENS units are they kind of go along with the physical therapy thing. In a little bit, when I talk about stimulators, patients will ask me all the time, is this just a TENS unit? And the answer is no. Okay. It's thought that it might work in a similar idea, this gate control theory, but the TENS unit is an external thing. It does seem to help reduce pain and certainly is a less aggressive and non-invasive option. Opiates, you guys all know, I don't have to tell you, it's all over the place, all over the news. Opiates are unfortunately just not a long-term viable option for most people. And in my experience, people who are on low doses on an as-needed basis tend to get some good relief. So for instance, once a week when I cut my grass, if my back is killing me and I take a Vicodin, those people tend to find relief with it. People who are taking it every day, scheduled, over some period of time, it just does not become, or becomes less and less effective. You get that tolerance to it. But then there's a lot of other issues that don't get attention, particularly the hormonal issues that happen with long-term opiates, decreasing testosterone, obesity is associated with them. So it's just, we don't want to go there unless we absolutely have to. Drug pumps are part of the opiates. There's other things that can be put in the pump that are not opiates. We're not going to touch on that a ton, but it is an option for some patients. So then we get to the surgery, which surgery really should be kind of down at the way at the end of this, right? Nerve block should have been moved up. So some of these minimally invasive injection type things, epidurals, nerve blocks, that kind of stuff, and then surgery if those things fail. For a lot of patients, particularly with spine pathology, the surgery is going to be worse than dealing with the underlying problem. Okay, so people, particularly backs, they're not like cars. They're not like take a piece out, put a new piece in, and they work. Backs are more complex than thinking about like a knee replacement. You think, oh my gosh, well, I went in, the orthopedist put my new knee in, feels great, right? Unfortunately, we can't do that with the spine. So when there's multiple levels particularly involved, when you start doing these bigger surgeries, there's some negative consequences for a lot of patients. So if your back's against the wall, your stenosis is so bad, your legs are killing you, we've done this conservative stuff and you can't get comfortable, surgery is a great option. It works really well for that type of thing. But it does come with some downsides, and we have to be prepared to deal with those. And for, depending on what you read, up to 10%, I think that might be a little bit high, of patients who have back surgeries for stenosis still have pain afterwards. So forgive me if you're my patient, I've already explained this to you, but this is the best analogy I have, okay? So you take your water hose and it's across your driveway and you're watering your garden, your husband drives up, car is parked over top of it. Stops working, water starts coming out, right? So he pulls off, you tell him to get off of it, he pulls off, water starts coming through again, but it doesn't seem to be working quite right, okay? It looks up fine on the outside, there's no compression, it's popped back up, but it's not working quite right. It can have cracks and be damaged on the inside. That's sort of what happens for a lot of patients with nerve problems. So the nerve is damaged, it's sending this signal to the spinal cord, which is ultimately going up to the brain saying, hey, there's a problem, hey, there's a problem. Even when the surgeon took the pressure off of it, the anatomical problem has been fixed. And that's when some of these other interventions start becoming necessary. All right, so I'm going to hit on radiofrequency ablation, which is RFA for short, okay? And then we'll talk more in detail about the stimulator. All right, so RFA is a long-standing treatment, been doing it for forever. It's minimally invasive, outpatient, in the office type of thing, okay? So if you look down at the bottom of the screen right now, it's saying back, knees, hips, neck. For the spine, it is the best right now in terms of what it can do. So when we're talking about this, they're talking specifically about joint pain. So this is not pinched nerve pain running down your legs, okay? This is joint pain. So the facet joints, F-A-C-E-T, you have a paired one on either side of the spine at each level, okay? And they connect the segments. And over time, you get arthritis in them. As our discs wear down, those are the main shock absorbers. When they stop being able to do what they need to do, they offshoot that stress onto those facet joints. And those facet joints are meant to take on much less strain than the disc is. So they start to feel that more. They're already a little arthritic, and then you end up with that back pain. Now, facet pain can radiate or refer into the leg, but it's not pinched nerve like classic, like sciatica type. So initially what we do is we do something called a medial branch block. This is a diagnostic thing. And so you numb up the little feeling nerve that goes to that joint, 2 nerves for each joint, okay? And then we go provoke your pain. So does it hurt more when you're getting up out of a chair? Does it hurt more when you extend and rotate, which is kind of classic for that type of pain? If the pain is very significantly improved when that nerve is numb, treating it with radiofrequency ablation then makes sense. So with radiofrequency ablation, instead of just taking a needle and dropping it down on the nerve, putting a little lidocaine, the needle goes along the course of the nerve and we heat it up. And basically that nerve's going to die back. Takes a few weeks to completely go back, but it's going to die back. And then once it's gone, you're going to have more pain relief, more sustained pain relief. It'll grow back, but it doesn't mean when it grows back, you're necessarily going to have as much pain. Now, this is similar idea if you've had facet joint injections where you're injecting steroid into the joint. But there's a couple of reasons why this might be beneficial for you, okay, as compared to the facet joint injections. First off, if the facet joint injections are short-lived in duration. Now, if you're getting 9, 12 months of pain relief out of a facet joint injection, that's great. You don't need anything. But if you're getting, 6 weeks, 8 weeks, that kind of thing, you can't keep getting steroids all the time. So that's when something like this, it would be longer duration of relief would make sense. Also for patients who have osteoporosis, and we don't want to give them extra steroids if we don't have to. For patients whose diabetes isn't as well controlled when they get steroids, that's when this type of thing would make more sense for you. Now, you see here, it's got knees and hips. Hips, it's not really perfected yet. I'd love to say that we're there with hips, not really perfected yet. There's some good ideas about the innervation or the nerve supply to the front of the hip capsule. The problem is the hip capsule gets nerve supply from behind as well. That's the sciatic nerve and some more important nerves that control muscle function. The only nerves we want to get ablate are these little feeling sensory nerves. Okay. Knees, we're doing much better with knees. And so that's something called a genicular block. Same concept, but we do the block first, make sure it works, and then we can do the cauterization or the ablation. And that's something we do quite a bit on people who've had knee replacements. The knee looks great, structurally is fine, but they're still having pain. All right, so let's move on a little bit to spinal cord stimulation. Oh, before I go on to that, I hear patients very commonly who have pinched nerve pain come and tell me that a doctor told them that I could burn that nerve. You don't want me to burn that nerve, okay? You don't want me to burn the nerve that controls the strength to your leg. So if we're looking at back pain referring into the buttock or the leg from the facet joint, this makes sense. If we're talking about pinched nerve pain that's going down, all the way to your feet kind of thing, it's unlikely that radiofrequency ablation is going to be the ticket. All right, so let's talk about the stimulator, okay? So this has been around almost as long as me. So this is nothing new. This isn't anything that we just started doing, but it has gotten so much better over time. So like I said, I've been here about 12 years. And so then I was in residency and fellowship for 4 years before that. So in that entire time, I've seen quite a bit of change in what we're doing in terms of radiofrequency ablation. I'm sorry, in terms of spinal cord stimulation. And so we have gone from systems that could do very little to systems now that can do an immense amount of programming, okay? So what do we use this for? We use this for nerve pain, so it's not that rotator cuff type pain, it's not knee arthritis pain, it's more of a nerve origin. Trunker limbs, okay? So we can use it for neuropathy, failed back surgery syndrome. That's when I was talking about those people who had surgery, the anatomical problems better, they're worse. Spinal stenosis type pain, something called complex regional pain syndrome, which fortunately is a rare thing, but does happen. Post shingles pain, post-herpetic neuralgia that isn't going away. So there's lots of things that we can use this for. So we don't want, this isn't obviously, I'm putting something in you, so I'm not going to do this day one that we meet and you've had pain for a week, right? So we're talking about chronic pain, which has been at least 6 months. And we want to make sure that you've tried the easier things first. That just makes good common sense, right? We're going to try the easy stuff first. If the easiest stuff doesn't work, then we're going to do this. Now, FDA approved, not drugs, but let me kind of go over, let me see if this next slide tells you, yeah. Let's go this one. Okay, so let's talk about really kind of how it works, because this is really the nitty gritty, like what's important about it. Some people will describe it as like a pacemaker for the spine and that kind of thing. I don't like that because it implies there's something wrong with your spine and I have to control it some other way. This is really a way to decrease your brain's concentration on the pain, right? So the new systems, the older original system did something called paresthesia based, which is one that you feel. So you feel a tingle, a vibration, or a buzz. The newer systems, you can still do that, okay, tried and true, that does work quite a bit. But then we had a portion of people that were hanging out saying, I don't like that stimulation or it doesn't help me, all right? And in my experience, that was more in people particularly have lower pain, like in their feet. And if you have neuropathy and your feet are burning and buzzing, and then I give you another sensation on top of that, for some patients that was sort of noxious, that was kind of annoying. So then now we have the high frequency, and what high frequency does is it stimulates at such a high rate that you don't feel it, but it's able to block pain. This is not like a pain blocker like lidocaine. Okay, this isn't like you're not going to be able to walk, or you're not going to feel yourself moving, or you're not going to know if you hurt yourself. It's not like that. Okay, so what happens is a little electrical lead. Let's see. No, a little electrical lead is put into the epidural space. So the epidural space is the space of fat and blood vessels in the spinal canal, outside of the sac where your spinal cord is. And so when you say epidural steroid injections, when you come in and get those, it's going into that epidural space. If you have an epidural for labor and delivery or for surgery, it's going into that space. Instead of a catheter that's releasing medicine, however, it's going to be this little electrical lead, and that's going to stimulate the back of the spinal cord. And then we're going to stimulate at the spinal cord level that corresponds to your pain. So for instance, most common is going to be low back, buttocks, legs. Okay, so your spinal cord ends about where your thoracic and your lumbar come together. Below that is just a sac of nerves. Only in certain situations am I going to stimulate low down like that. Most of the time, I'm going to stimulate in the thoracic region, okay? And that's going to correspond to the spinal cord level of your back and your legs, right? It's initially done as a trial. So there's two things that I think set this apart, really. I mean, the data is clear. This works great. It's better for many patients compared to surgery, and far exceeds repeat back surgery for a good portion of patients in terms of pain relief, okay? So it's a great treatment, but the two coolest things about it is, number one, we try it out first before we put it in you permanently. And number two is you get to control it, right? So the trial part, I put it in you with a needle, cover it up with a big dressing, and you go home for up to 7 days, most patients 5 days, but up to 7 days. And you have an external piece that you wear during that time, and you can turn it on and off and up and down and adjust it to see if it works for you, right? So did you try out your back surgery? No, you got it. Did you try out your knee surgery? No, you got it, right? This, you actually get to see what it's going to do before we put it in permanently, which is just amazing, right? Once we know that it works for you, then we're going to put the permanent in. The permanent is a surgery. All right, the trial is just a procedure in the office. It's like an epidural, it's just a little more involved. The surgery, you do go to sleep for that, but it's an outpatient one. It is super quick surgery for my surgeons here at LSC. They are superb at it. Very, very quick surgery for them. And then you're home with the system working, and you can pretty much go back to normal. People are a little sore at the areas where they had the surgery at, but you can pretty much be normal right thereafter, as opposed to the bigger surgeries where you have long recoveries and physical therapy and all that kind of stuff. Now, all right, so let's talk about the trial period, okay? So during the trial period, reasonable expectations are everything, okay? Everything. So if I told you that I was going to make you pain-free, you should probably get up and run away. Okay, if the doctor says, I'm going to make you pain-free, you're never going to have to pain again, get up and run away, because chances are that's not going to happen, okay? In spinal cord stimulators, we're looking for at least 50% reduction in pain. Now, that is a big amount. I mean, people who have really bad pain, 50% is important for sure, okay? And most medicines get on the market, we're talking 30% pain relief. That's what's considered clinically significant, which is, I mean, that's important. You know, if your pain's a 9 and, you know, we're dropping it into the 6 range, that's a big deal, okay? But that's not blowing your socks off kind of thing, all right? What we're really looking at is functional improvements, okay? So if you have a trial with me and you come in to get the lead taken out, which if you've ever had a epidural at the hospital for surgery or anything, it's the same thing, you just pull it right out, okay? A lot easier coming out, okay, than going in. But what I'm going to ask, hey, did you like it? How was your pain? Okay, now tell me, what did you do this week? Were you sleeping better? Were you getting around the house better? Were you walking through the grocery store? It is very common for me to go in the room and patients tell me they did something they have not done in years, and they didn't have any problems. You know, patients tell me, I walked all the way through Costco, didn't stop one time. You know, I haven't done that, and I can't even tell you how many years. That's the kind of stuff that's like knock your socks off important, okay? And even sleeping better, right? I mean, poor sleep makes everything worse. You know, you don't sleep well, your pain goes through the roof. So better sleep is just as important as walking and exercising. Were you able to reduce how much pain medicine you need? Now, if you're on constant scheduled medicines, I don't want you to stop those for the stimulator, okay? But I do, if you use medicines as needed, I want to be able to, hey, I didn't need to take that extra Tylenol. You know, I was feeling so much better. That's going to be a marker of success. Now, I did hit on this with the two different ways that it works, but let me kind of backtrack because I think this is really important, okay? So you have the paresthesia free, and both combined, okay? So the newer systems, both combined, and that's pretty much what I'm putting in just about everybody is the one that can be combined. That seems to really make most patients have the most benefit, right? So they have the one system where it's stimulating at that high rate. They don't really know what's going on, but their pain isn't as bad. And then they also can have the one where they feel something. The paresthesia one, people tend to like that better during the day. The no feel, paresthesia free, a lot of people also call them no feel. They like that, or sub threshold, you know, different companies will call it different things, but not being able to feel it, most patients like that more at night. These systems now don't require as much of patient interaction with them. So once we put it in permanently, okay, you're going to get a battery. Is there a picture of the battery? No, I don't have a picture of the battery. Okay, so the battery goes, now for most patients, we're talking about lumbar. If it goes in your neck, it'll be a little different, but lumbar, it's going to go back, you know, below your belt line, not where you're sitting on it or anything. And it goes under about that much fat and skin, right? So if you grab it, there's something hard back there, you can feel it, but nobody can see it. It's not like if you have friends who are, you know, have a port for chemo or something and it's up here and it kind of sticks out. All of us have a little meat behind. So you're not going to be able to see it. Nobody's going to know it's there. The new systems are MRI compatible, and I don't put anything in anyone. I don't think at all anymore that's not MRI compatible. So that's full body MRI scans. It used to be with the older systems, you could only have CTs. You can have MRI scans now. There are some limits on the scanner that you can go in. It's usually going to be a closed scanner, not an open one, but it's a game changer to be able to still get full body MRI after having a stimulator put in, really a game changer. But what that allows us to do then is, you know, if we put this in and things get worse down the road, we can still look at it without having to go through a myelogram or CT scanner like that. Now, then you're going to have remote control. And it looks kind of about the same size as your television remote control. And that's how you're going to control it or adjust it. So you can turn it on and off and up and down and change the programs. It's really important that you get programmed a lot initially so that you find what works for you. And the lifetime benefit of having this is that you have these representatives and educators like Rachel who will meet with you. You don't have to have an appointment with a doctor. They'll come up here and meet with you and make adjustments for you so that you're getting the most out of this. So pain changes. It's not the same every day, right? It's not the same year to year. You know, I mean, I have patients who have rip-roaring sciatica on the right side for a year and it gets better. And now they have rip-roaring sciatica on the left side. So if I put in a stimulator for them and they got all of it on the right, now they need it on the left, they have to have somebody who can help them with that. And that's the beauty of this. We are able to control it and adjust it. All right. So this is just kind of telling you what I already kind of hit on about stimulators consistently in the medical research consistently work. You know, there's a lot of variability in medical research because it's hard to do things like you can't do controlled, I can't do a lot of controlled studies where I put sham stimulators inside people and have sham surgeries and that kind of thing, right? So it makes it very difficult to get great data. And over the years, we've gotten more and more and more data showing consistently that stimulators work, and they work well, and they work for a longer duration of time. You know, you're talking 2 years out, and that's a long time to follow people in studies, just so you know. I mean, a lot of these studies are looking at people 3 months, 6 months down the road, and now we're going, you know, 2 years out, and people are still doing really well. All right. So I think I hit on everything. Did I miss anything?
We've got good questions, so we'll hit those.
All right. All right. I'll be back for questions in a few minutes.
Yes. All right, we're just playing musical chairs here. Thank you, Dr. Andrus. I am going to launch a poll really quick. You're going to see it come up on your screen. If you're calling in and you're not seeing a screen, you won't see the poll. But basically, it's just asking if you'd like us to follow up to get an appointment with Dr. Andrus. So go ahead and take a minute to do the poll, and then I am going to get Miss Sandy here set up. Sandy, can you hear me okay?
I can, Rachel. I have no video, which is fine if you don't want me on video.
Let me see if we can get Sandy. All right, we're just working out some technical stuff. Gotta love Zoom. We're trying to get our patient ambassador to be able to speak. I'm gonna let her try to figure that out, and then we might do some Q&As. Can you hear anything, Chelsea, on your end?
Can you hear me, guys?
Okay.
Are you able to hear me now?
You can.
Can you hear me?
You can hear. Okay, Sandy, we can actually hear you. I'm going to work on getting your video up, but for now, if you just want to speak,
You're able
go
to hear
ahead
me?
and I'm going to introduce her. She's going to share her quick story. She is a patient with a Boston Scientific stimulator. She is not a patient of Dr. Andrus, but like I said, she's a volunteer patient willing just to kind of share her personal story, and then we can address some questions towards her as well. So go right ahead, Sandy. Thank you.
Hi, thanks, Rachel. So I have had my Boston Scientific spinal cord stimulator since 2008. I had woke up from sleeping one morning over a Christmas vacation. I'm a public high school teacher, and I couldn't get out of bed. I had excruciating pain. I did not have an injury or anything that I know of. I just woke up and I couldn't move. A little bit stubborn, and I did not want to go to the hospital. So I just had my husband carry me back and forth to the bathroom and back during that Christmas vacation until my doctor's office opened. And when he did, my husband brought me down, carried me in, and the doctor promptly put me in the hospital for obvious reasons. I had excruciating pain in my lower back and down my left leg. When I got to the hospital, they admitted me, they did an MRI, and I had a slip disc. Again, I don't know how that happened, but it slipped. And the surgeon removed the part of the disc that had slipped out, and I woke up from surgery and I felt great. All the pain was gone. 9 months later, I wasn't feeling so great. The pain had come back. They did another MRI and determined that the rest of the disc had indeed slipped out. So the surgeon went in and shaved off the rest of that. I did not have great results after that. So I went through 2 years of all the things that Dr. Andrus pretty much talked to you about. So I went through TENS units, I went PT, I did injections, medications. I had the full gamut, I think. And just to the point of frustration, I was out of work. I finally said, there's got to be something else. I can't live the rest of my life like this. And my pain doc said, I think you're a good candidate for a spinal cord stimulator. So again, we're back in 2008. I had no idea what that was. Nobody did. I had no patients really to talk to. I shouldn't say nobody did, but nobody that I knew of did. I didn't have any patients really to talk to at the time. And they just sent me home with some DVDs and said, look at these and see what you think. And I came back to the doctor and I said, well, we'll give it a try. And in my mind, I think, Dr. Andrus, you kind of used my line there without even talking to you first, is the whole thing about try before you buy, I think is how I look at it. When they told me I could do a trial and it wasn't any permanent surgery, I figured I really had nothing to lose at that point, because I was in so much pain and I had tried everything else. And I was so frustrated that I was like, sure, let's do it. And I remember vividly looking up at the doctor during that trial, and they turned it on. Boston Scientific was in there, turned it on when they put the trial in. And I said, why didn't we do this in the first place? And the doctor kind of looked at me and he said, we have to try everything else first. And I was in awe at how amazing the feeling of it was, and the pain was gone. So I was looking to get off of some medications and get back to doing some of my activities. And much to my pleasant surprise, I got back to all of my activities. And I'm very athletic. I played high school and college sports, basketball and all that. And I'm still very active today. And I'm doing everything and more that I could do before my spinal cord stimulator 12 plus years ago. And so it's been wonderful for me. I don't regret the decision at all. I'm really glad I did the trial and was able to have the permanent implant. I know it isn't for everybody, and I'm certainly not here to sell it at all. I'm just here to tell my story and how successful it was for me. And every time I hear the options of other things other than opioids, because we have that epidemic of opioid bad things going on in our country, I always think, why aren't we using more spinal cord stimulation? Because there's no medications in it, and it's just wonderful pain relief that's not doing bad things to our body. So for me, it's been great. I just can't say enough about it. And I do this voluntarily. I speak with patients who want to learn more about it from a patient's perspective, because it gave me my life back. Without it, I don't know where I'd be, but I certainly wouldn't be doing any of the things that I'm doing now. I'm back working, and it's just been a wonderful experience. So that's a little bit of my story, and certainly Rachel can put you in touch with me or any of the other patient ambassadors if you wish to speak to any of us that actually have the device and can answer questions from a patient perspective.
All right, thank you so much, Sandy. I appreciate you getting on and sharing your time today. It's just exciting to hear how even after years and years of having your stimulator, you're still able to get the results, live your life, be active, just like Dr. Andrus was talking about. It's the function, it's getting back those things. So thank you for sharing your story. We did have a question come in before I have Dr. Andrus jump back in. She's got a stack of questions. Y'all got some good ones today. There is one that I think Sandy can answer. It is, how easy is it to charge your battery? I think that's a perfect question for you, Sandy, if you don't mind taking that one.
Certainly, and that's a common question I do get quite often. So everybody's different in that respect in terms of how much they need to charge. I charge about every other day for about a half an hour. And the nice thing about the charging is you have two ways to charge. You can use a belt that you put the little charging, I call it a charging puck. It looks like a little hockey puck. And you put it in a little belt that you Velcro around your waist, and you can pretty much do anything you want. I do the dishes and I vacuum and I do all sorts of things while I'm charging. So it's not wasted time where I'm just sitting there doing nothing. Or there's also sticky pads where you put a sticky pad on and put it right to your skin. And that's really personal preference. And or maybe it might be just unique to you that you need to use one over the other. So there is a couple of different options, but yeah, for me, it's about every other day, about a half an hour.
All right, thank you. Okay, I'm gonna have Dr. Andrus come back up for a minute. Like I said, y'all have making her work today. Feel free, we'll try to get to as many as we can. again, we'll follow up with everybody that asked a question, but I'm going to hand it back over to her.
All right. Y'all do have a lot of questions. Either I wasn't very effective or you guys are
Smart.
really smart. I think it's probably you guys are got a lot of good questions. All right. So how effective is a stimulator for patients with neuropathy of the feet? All right, two things we want to think about, okay? With neuropathy, most of the time it is not reversible, okay? So the stimulator is a treatment for pain, is not a treatment for cure of neuropathy, okay? Two sets of symptoms with neuropathy. You have positive symptoms and negative symptoms, okay? So positive symptoms are the burning, the tingling, the stinging, the feeling like you're walking on cotton, that kind of stuff, okay? The negative symptoms are the loss of sensation, like I can't feel things when I step down, the impairment in balance. That stuff, unfortunately, the stimulator is not going to work for. The pain stuff, the discomfort stuff, it will. So I always ask my neuropathy patients, because I know nerve pain is hard to describe, to really tell me, is this just pain or it just doesn't feel right? If it just doesn't feel right, unfortunately, stimulators and medicines don't work for that. If it hurts, it's stinging, it's burning, it's aching, it's throbbing, that kind of stuff, that a stimulator does work for. And like I said earlier, the high frequency tends to be more well tolerated for stimulation for the feet. All right. Are pacemaker patients limited from this procedure? The pacemaker itself, no. If you have a defibrillator, yes. So if it's a pacemaker with a defibrillator, no. If it's just a pacemaker, we can do it. That being said, if you have a pacemaker, you have to be healthy enough to do this. Okay, so if you're on blood thinners, you have to be able to temporarily stop the blood thinners. That's a very important aspect of this. Okay, you have to be able to safely stop blood thinners for this procedure. So if you are in a precarious situation where if we stop those thinners, some negative outcome may happen for you, we wouldn't want to do this because it is a more prolonged period of time that you have to be off of. All right, so someone says, I have constant pain in my left hip. Do you think this treatment will help? So that's super hard to say without seeing you. Hip, buttock, low back are conglomeration of issues, unfortunately. It can be from the spine, it can be from the pelvis, it can be from the hip. So you have a lot of structures that can get involved there. If it is from a nerve source and not a muscular source, then yes. So a lot of patients will have pain, they call it their hip, but it's really more kind of like up in your butt. Your hip is typically felt in your groin, sometimes in your butt, sometimes on the outside of your thigh. But most patients say their hip will kind of like grab their low back essentially into their buttocks and on the side of their hip. Oftentimes that is from the back, and oftentimes this treatment does work well for that. But just need to see the doctor and kind of tease out what the cause of yours is, and then we can tell you a bit more. Is the implant procedure reversible? Yes and no. Okay, so can we take it out? Yes. Do we want to ever take it out? No, not really. So only if there was some complication or issue would we typically take these out, right? So you do get scar tissue around it. And you know, the surgeon doesn't want to go monkeying around with scar tissue in your back, near your spinal cord, unless there's a good reason to do so. Once in a blue moon, I'll have a patient who just does so well over time and they've gotten so much better and they say, I don't think I need this thing anymore. What I usually tell people at that time is turn it off and keep it charged and keep it in. Because if you take it out because you say, okay, I'm good, I don't think I need it anymore, and then 5 years from now you have that same problem, it's going to be very tough to try to put a stimulator back in. Scar tissue along in there. So usually I tell people not to mess with them. In the past, when they weren't MRI compatible, this actually was more of an issue. But now that they're MRI compatible, it's really not so much of an issue anymore. All right, so is there a difference between nerve blocks and an epidural? Some people use them interchangeably, but in what I was discussing here is quite different. So epidural is going into the space of fat and blood vessels where the nerves are exiting out of the spinal canal. The idea between epidural injection for pain, okay, not an epidural for surgery, but an epidural for pain is to reduce inflammation, swelling, and pain, okay? An epidural for surgery is to put a bunch of numbing medicine and sometimes opiate medicine in there so that you don't feel and can't move, okay? So that's different. Now, nerve block is just to provide anesthetic where the nerve is coming out, right? So a nerve block, for instance, would be done oftentimes in patients who have a foot surgery. Okay, a lot of patients will get something called a popliteal nerve block. So behind the knee, anesthetic will be placed. Patients having shoulder surgery will have a nerve block where we block part of the brachial plexus so they can't feel or move there. Nerve blocks in the spine, like I was talking about earlier, are specific to the little feeling nerves of the facet joint, and those are a more temporary thing, more diagnostic. Will spinal cord stimulation allow me to be free of pain meds? I hope so. It's hard to know, not knowing you and your backstory, but I can tell you that most of my patients significantly reduce them. I do have some patients who will still remain on some of their nerve pain medicines at reduced dosages after. Most of them don't need them at high dosages anymore. Some of them may still need a little bit here and there for some of their pain. The main goal, however, though, is to be able to reduce your medicine need. And so we want you to be able to do that. But remembering that this is treating the nerve component of your pain, it is not treating the mechanical component of your pain. So if there is a mechanical issue that is still causing some discomfort, we're going to want to try to fix that mechanical problem. But if we can't, there may be some medicine that's still involved. What is progression of treatment? So I'm not quite sure what you're meaning, but I'm going to give you a basics in case I'm missing something. Okay. So usually when we see you for a chronic condition that you don't have anything on your exam that's concerning. Now, if you come in here and you have foot drop, for instance, I'm not going to put you through any paces. I'm going to go straight to figuring out if that's coming from your back, and we're going to go straight to talking about something like surgery. Okay. But assuming that there's nothing on exam that looks like a neurological problem, okay, we're going to start simple stuff. We're going to start with some of the simple analgesics that don't have as many side effects. We're going to start with physical therapy to address a lot of the secondary myofascial musculoskeletal issue. Okay, that doesn't work. Then we're going to look and see if there's some type of intervention that we can be doing that's going to be helpful. Is that an epidural? Is that radio frequency? Something that can provide some reduction in your pain. And we may step up our game in terms of medications and start talking about pain medicine, which can come with more risk than some of the simple analgesics. Those things don't work, and you have a condition that would benefit from a spinal cord stimulator. Then we're going to start talking about a stimulator. Now, one thing I didn't hit on earlier is there are a couple of requirements before we do it. One is a psychological screening, and one is an MRI of the body part that I'm going to be putting the stimulator into. Okay, so the thoracic spine. Why do I need that? Very few people have stenosis in their spine, their thoracic spine, but some people do. And it would not be safe for me to place my lead there, so I need to know that before I get involved with that. Second thing, the psychological screening. Please do not think it's because I think you're nuts or you're crazy or you're making it up. I don't think that at all. If I thought that, I wouldn't ever want to put a stimulator in you. So don't think that at all. Insurance knows that pain is a subjective experience. The very definition of pain is a subjective experience. And we all know people who experience that as a lot of anxiety. Okay, so we know lots of patients. We all have friends and family that experience their pain as a lot of depression and anxiety. Do you think I'm going to make that better with a stimulator? No. Okay, so what we need, it doesn't mean you can't be depressed and you can't be anxious, because that comes hand in hand with chronic pain. Okay, vast majority of my patients have some degree of depression and anxiety to be expected with their diagnosis. Okay, what we're talking about is uncontrolled. Okay, uncontrolled substance abuse. We know that when people have uncontrolled substance abuse issues, they're not going to do well with anything. All right, so what that screening is just to say, hey, do you have reasonable expectations? If you tell the psychologist, I'm going to be 18 and run a half marathon, and you're 78, he's going to say, go back down the hall and talk to Dr. Andrus again, because that's not what's going to happen. Okay. If you say, this is so stupid, but my wife made me watch that Zoom thing, and she said I should try it because she doesn't want to hear me complain about my pain anymore, he's going to say, go back down the hall and talk to Dr. Andrus again, because those two ends of the spectrum aren't going to do well, right? Everybody else in the middle is going to do just fine. It's not a big deal to go through that screening, okay? After that screening, then assuming those things are fine, which they'll be, then we'll move on and do the stimulator trial. All right, what age do you recommend this device for? Is there an ideal age range? No, there's not really an ideal age range. Now, In young people, okay, particularly in young ladies, I do tell them that there may be some issues down the line if they're planning on starting a family in terms of labor and delivery epidurals, not because they necessarily couldn't have one, because the anesthesiologist who's on call comes in at 3 a.m. and you say, oh, by the way, I have a stimulator in my back. And they say, I'm not feeling it. I'm not going to put another thing in your back because I don't know what that is. Okay. So that's always a question, you know, and that we have to address. Otherwise, not really a specific age, not in children, you know, we want this to be in adults. Now, you have to be healthy enough to put in the permanent. That's the real caveat. So if you're 95, we're going to have a real serious discussion about, do we really want to put you to sleep to put something in? Okay, that's really going to be where age matters. Can we touch on fibromyalgia pain? That is a huge topic. And but what I'll tell you is that we don't put stimulators in for fibromyalgia. Okay. That being said, lots of patients with pain, there's primary fibromyalgia and secondary fibromyalgia. Now, the American College of Rheumatology, they got rid of the secondary classification and that kind of stuff, but I think that it still has a lot of utility. Okay. So primary fibromyalgia, those patients, that's really their main diagnosis. That's the thing that's wrong with them. Okay. Down the line, they may get hip arthritis and all the other stuff, but the main issue is that fibromyalgia. Secondary fibromyalgia is this idea that the longer you hurt, the better you get at hurting. So we all kind of think that, well, I've had pain forever, so I'm really tough to it. And actually the opposite happens. Like your pain threshold, meaning that if I push on you hard, I may have had to push twice as hard before to make it hurt. And now I can press half as hard and it hurts. That threshold comes down. Now you may be tough mentally to the pain, meaning that you still move on, life still moves on, you're still taking care of your family, you're doing all that type of stuff. That toughness definitely exists, but in terms of the intensity of the pain, that actually gets worse. Okay, so that's what I kind of classify as secondary fibromyalgia. That stuff tends to get much better if we treat the primary pain, whether that be back pain or whatever. All right, what is the healing time from the implants or the permanent? Couple weeks. We don't want you to do a lot of rigorous activity, and depending on the surgeon, they'll say 4 weeks, 6 weeks, 8 weeks. We don't want you golfing and that kind of thing, because even though this is sewn in there, it's not going anywhere. We don't really want it to have any wiggle at all. Okay, just want it scarring really nicely. Back where they put it is a little sore for a couple of weeks, but you go home and you go back to normal activity the next day, unless you have like a really strenuous exercise regimen or a really strenuous physically demanding job. Then we'll put someone that's on that for a few weeks. Is this helpful for herniated disc and other degenerative issues? Great question. Yes, is the short answer. Okay, so a lot of patients fall into these gray zones where they're not quite at a surgery level, but they have a lot of pain from that pathology. In those patients, we do a lot of stimulators, and with the idea that we're trying to improve their pain, trying to stave off the surgery. That surgery may still have to happen down the line, but we're trying to postpone it. So for instance, if you're in your 50s, you really don't want your back fused unless you're in a corner and you have to. Okay, so this is a good thing to try in many patients, assuming that they don't have such bad stenosis that they have neurological problems. We also do this quite a bit in people who had surgery some years ago and the levels above their fusion have gone bad, and they don't want to have that progression of surgery. The surgeon isn't excited about fusing up several more levels. So in those cases, yes, this is helpful. So I've had both knees replaced. I'm told I'm functional, but I'm not able to work. My balance is bad and I can't do the things I used to enjoy. Is spinal cord stimulation an option for someone like me? It's kind of tough not seeing you to know. Balance being off, probably not, unless that's pain related. So I think in this situation, it'd be best to lay hands on you, because there's probably some other things that we could do besides a stimulator, maybe even that radio frequency ablation for the knees. And then how do I get more info on RFA? We have some things here in the office. We have some, when we schedule people, we have some information that we give out that can be helpful for you. All right, so I have got to call it, guys. There's a lot of questions. Thank you very much for listening to me and for getting on, spending your evening with me. And hopefully we'll see you soon in the office. Night.
Thank you. Thank you, everybody. Thank you, Sandy. If we did not get to any, I think we had a couple more questions, but Zoom's about to kick us out in a few minutes. Chelsea or I will be following up with each of you and making sure everybody gets an appointment with Dr. Andrus that asked for one. Also, just something on the screen, there's Dr. Andrus's phone number. If you're jumping and want to get in touch with her before we even call you, please do. You can also visit controlyourpain.com. That's the Boston Scientific resource for patients to learn a little bit more. I know someone asked about RFA, some resources that's on there as well. So thank you again, and we'll be seeing some of y'all in the office. Have a good night.